And we're going to talk about spina bifida, and this is a congenital neural tube defect characterized by incomplete closure of the vertebrae in the neural tube during fetal development. Spina bifida is classified as spina bifida culta and spina bifida cystica. And you'll see on page 743 in your book or on this slide here, spina bifida culta usually occurs between the L5 and S1 vertebrae with failure of the vertebrae to completely fuse. This child, if the child is born with a culta, will probably not have any sensory or motor defects, and the only clinical manifestation may be a dimple, a tuft of hair, hemangioma or lipoma in the lower lumbar or sacral area. It's usually just detected accidentally on X-ray. Spina bifida cystica is a more extensive defect with a range of sensory and motor impairments, and that's what we are basically going to focus on today. The cause of spina bifida is unknown in most cases. Evidence suggests that there's a possible genetic predisposition, and maternal folic acid deficiency has been strongly linked to neural tube defects. So daily consumption of 0.4 milligrams of folic acid by all women of childbearing age is recommended. There's also evidence of a viral origin has prompted some research, but other than the folic acid, there's no cause or preventative measures that have been identified. This slide just gives you a really good picture of what the infant is born with spina bifida, and what kind of defects, as you can imagine when you look at this slide, depending on where that meningocele is at in the vertebrae itself. So you can see that there's going to be different degrees of deficit as you deal with the infant as they grow, neurological deficits, and we'll talk about those in just a few minutes. This next slide just goes over the signs and symptoms. The myelomeningocele tells you about the myelomeningocele, how it doesn't completely form, causing the spinal cord and the meninges to stick out. So out of the back itself. So if you can only imagine, if you've never seen one before, you can actually see the sac and on the back of the infant. In spina bifida culta, the bones of the spine still do not close, but the spinal cord and meninges remain in place, and the skin, covers the defect, as we talked about earlier. Meningoceles occur when the tissue covering the spinal cord sticks out of the spinal defect, but the spinal cord still remains in place. So, as you well can imagine, the signs and symptoms is determined by that level of the lesion itself on the spinal cord, and the deficits will be seen according to that. On page 744, it gives a really good picture of the infant that has had a repaired myelomeningocele. You can notice the left club foot, because a lot of times they're born with a lot of different abnormalities as well. Usually with this child, it's stating that the legs are flaccid, normal neonatal flexion is absent. The infant also dribbles stool and urine constantly. So when we look at these with these little infants, we're looking at them neurologically and what they can do motor-wise from that lesion, maybe up a little bit further because of inflammation after surgery, and below that lesion. And as you know, there's innervation from to the bladder and to the bowels. So a lot of times these infants will have incontinence. They have no nerve intervention to hold their urine, hold their bowel, and that's really important that we explain to parents that that's something that they're going to have to deal with all of their lives. these children, but there's ways that they can deal with them as they grow, and we'll talk about that in just a few minutes. This slide just basically goes over some of the signs and symptoms, especially if they have their level of disability is, like in the L area and down. The higher the defect is, the worse prognosis it is. I've seen a child that had a very, very low spina bifida. The mom just said, well, she had back surgery, and that's all she thought that was going on with the child. But she was ambulatory. The only thing, she was incontinent, a bowel and bladder, and we couldn't figure out how come. She went into kindergarten, and of course the teacher and the students, because of the smell, couldn't understand how come she wasn't holding her urine, and the mama really didn't know either. So nurses had to get involved with that case, and we taught her how to do self-catheterization, and we had to put her on a bowel regimen. That was real important. On this slide, it just kind of goes over some of the prenatal screening they can do, an AFP, which is alpha-fetoprotein. They can do some genetic testing, and they can also do an ultrasound or amniocentesis, which can detect the deformity, and this can be visualized. So if this is done beforehand and they know that the child has spina bifida, and the mother wants to go ahead and have a viable infant, then what they'll do is they'll do a C-section, so there's not pressure on that cord. So that's a important aspect of it, because the more pressure we put on the cord as the baby goes through the vaginal canal, the more deficits they will have neurologically. So genetic counseling will be needed for the parents. Some mothers may elect for a therapeutic abortion. After birth, surgery is used to repair the meningocele. Antibiotics are used to prevent infection, and analgesics are used to prevent and relieve pain. The infant needs to be carefully handled prior to surgery to prevent any harm to that exposed spinal cord and to prevent infection in the spinal cord. As you can see in figure 28-3, they use kind of a little screening over from the surgery down to cover, so we can kind of separate the urine and the stool from the actual surgery site itself. A lot of times they'll use like it's a sterile saran wrap, especially, or they'll use normal saline 4x4s to before surgery, just to keep that the myelomeningocele covered, and hopefully, free from infection, because that's huge. As you can see, this baby is on his, kind of like on his side, on his tummy, and pre-op and post-op, you would want them on their sides, and never ever to put them on their backs, because that would only increase pressure, and we wouldn't be able to see the site, which we need to always observe the site for any type of infection. Of course, these kids need lifelong follow-up care, physical therapy, and neurological problems. Maybe if they have clubfoot, then they may have to have surgery for that. If they are paralyzed, from the lumbar region down, then they'll be in a wheelchair. They'll have to have constant watch for UTIs, and many, many years ago, spina bifida children died of renal failure because of the reflux back into the kidneys. Now we do self-catheterization, and we teach parents how to cath their children, their infants, their babies, up until about 3 years of age, which normally normal able-bodied children or are starting to achieve toilet training. So we start teaching the parent to teach the child, or we start teaching the child in school about self-catheterization, and that starts just basically with, it's a clean catch, and they just start washing their hands, and they can get all the equipment ready. They have catheters at home that mama just cleans in between, so it's a clean system, and it gives the child a sense of autonomy and a sense of control over their bodily functions, and it gives children more freedom, and prevents. It helps with self-image. These are children that will typically smell if they are constantly dribbling urine in their diaper or urine in their brief, and they go to school, and as we all well know, children can be very, very, very mean. So this is a way that they can have some control. They usually self-cath four times a day. Before they, when they wake up in the morning, just kind of like a routine, like when we void. One time in the morning, maybe when they get to school, maybe just after lunch, before they eat dinner, and maybe before they go to bed at night, just depending on, oops, the boys are barking. Sorry, the boys are barking. Maybe just before they go to bed as well. It gives them that autonomy, and especially if they ever want to spend the night with a friend, it really helps with their self-image. So our nursing care will focus on prevention of infection, pain control, protecting that spinal cord. Patient education will include the incisional care after surgery, depending on what the neurosurgeon, orders. The importance of making follow-up all on appointments, the names of various resources and support. It's important also to teach women of childbearing age who wish to become pregnant, to take folic acid. Go ahead and start taking those prenatal vitamins as they are trying to have a child. And I love this little picture because there's Jennifer Biggers and Amy Sethel. They both have the same type of spina bifida, but every person's condition is unique, and they're neat kids to know. They are very, very social children, and very special, as every child is. So, hope this helps, and if you have any questions, remember to go to the Q&A. Thanks.